Hi everyone, welcome back to the very last formal lecture of health economics. The next scheduled class time, I'm going to go over the project, so it won't be like a standard lecture. So this is a day we're celebrating that you finally made it to the end of this class, and hopefully it hasn't been incredibly painful. So we're going to finish up on the American model today. As I kind of mentioned last class, I'm going through this in parts, and what we're going to move on to today is part 2 of the American model, which is the managed care alternative. So in private markets, insurance companies can come up with innovative ways to do things, and one of the biggest new ideas in health insurance in particularly America is managed care. What is managed care? The technical definition of managed care is health insurance plans that use tactics intended to reduce moral hazard and physician-induced demand. If successful in reducing health expenditures, managed care plans can charge lower premiums. Okay, so a little bit of background on managed care. Up until the 1980s, the U.S. private insurance market was dominated by fee-for-service. Fee-for-service effectively meant that if a person had insurance, they would go to their doctor. It was between the patient and the doctor to figure out what services the patient needed. The doctor would just keep a list of all the services they gave their patient, and then the insurance company would just pay the doctor a fee for each service, and there was no kind of like lists of things that were covered and things that were not covered. So during that kind of era, customers could choose their doctors. Again, it was up to the customers or the patients and their doctors to decide what care was needed. And then once a patient received the care, the insurance company just paid the doctor or the hospital a fee for each service. And then the payment was just based on the tally of whatever services the doctor or hospital provided. And again, importantly, during that pre-managed care era, coverage for specific treatments was rarely ever denied. Okay, the problem with this traditional fee-for-service setup was that it did very little to control moral hazard. So the idea of moral hazard is if you have insurance, then it kind of incentivizes people to overutilize healthcare. And in particular, if fee-for-service was kind of the name of the game, then doctors had kind of every incentive in the world to just give their patient a whole bunch of services, because if the insurance covered company was not going to deny payment for anything, then why not just give their patient a whole bunch of stuff, and then the insurance company will pay for all of it. Okay, one exception to kind of the fee-for-service setup was something that was going on the West Coast during World War II. So during World War II, there's a man named Henry Kaiser, and he won several federal grants to build Liberty warships. And so once he got those grants, he needed to employ a whole bunch of people to build these warships. And so almost overnight, about 500,000 workers just flooded into this area of California to start building these warships. The problem was that medical care was really hard to come by, so Kaiser adopted a solution, and the solution was that he would charge his workers a premium for health care, and then he himself would deliver it to them and their families directly through company-owned clinics and hospitals. So to run the plan, Kaiser appointed a man who was both a physician and an entrepreneur named Sidney Garfield to administer his idea. Garfield had done this before for Kaiser for earlier construction projects in Washington and Southern California. And so the idea was that Kaiser hired Garfield again. He said, move to California. We've got all these people working on the warships. They're having a hard time kind of getting medical care. Let's just like build some hospitals, hire some doctors, and then let's just have these company-owned hospitals and doctor's office that our employees can come to. Okay, it worked great. And so after the war, when the employment in the shipyard started to dwindle, Garfield took this idea and he began marketing the Kaiser plan to the public. And today, you've probably heard of this, Kaiser Permanente is one of the most prominent managed care plans in the United States. And it was kind of one of the first instances in kind of this very vertically integrated healthcare provision. And it, in a lot of ways, became emblematic of what managed care looks like today. Okay, so specifically, how was the Kaiser plan emblematic of managed care? For one, the insurance would not pay for appointments with doctors outside of the Kaiser hospitals and clinics. So the idea is if you work for the shipyard and you wanted health care that was provided by Kaiser, your boss, well, then Kaiser would say, come to my clinic. I'll give you free care at this clinic that I am opening and financially supporting, but I'm not going to like pay for you to go to some other doctor outside of this clinic that I have because I built this whole clinic for you. The other kind of way that the Kaiser plan was emblematic of the managed care movement is that the insurance would not pay for specialist appointments unless it was first approved by the Kaiser primary care clinic. And then finally, the doctors that were hired by the Kaiser hospitals were salaried, and so they had no incentive to order like extra tests that were not really necessary. So the idea is that one of the problems with fee-for-service is that doctors, again, have an incentive to kind of do extra stuff to the patient just because insurance will cover it. But in the Kaiser clinics and hospitals, those doctors were getting paid salary by Henry Kaiser, and so they didn't get any kind of financial perk by just doing a whole bunch of stuff to the patients just for the sake of doing a whole bunch of stuff to the patients. So this really helped kind of rein in moral hazard. Okay, so if you look back at the definition of managed care, I'll read it to you one more time in case you missed the first blank. So managed care is health insurance plans that use tactics intended to reduce moral hazard and physician-induced demand. Okay, what are the tactics? Okay, tactic number one is managed care plans today use gatekeeping. So this was similar to Kaiser. Kaiser said, if you work for me in the shipyards and you need to go to a specialist, well, first you have to go to my doctor and my hospital that I built, and they have to make sure you actually need to go to the specialist, and if so, then we'll make a referral. The second tactic that managed care uses is they use coverage networks and vertical integration. So the Kaiser system was completely vertically integrated because the hospitals were built by a single person and the doctors were employed by that same person. And then the care that was provided in the hospital was free to the employees. And so there wasn't kind of separate parties that were like, you take care of the patient and then I'll separately pay you for the care of the patient. Like everything was very streamlined in terms of vertical integration. The third tactic was monitoring. So right now for managed care plans, like, so managed care plans are like HMOs and PPOs today. If one of the managed care organization puts a particular hospital on their in-network list, then the managed care organization usually keeps a close eye on the hospital and physician. They monitor them to make sure that they're not kind of treating the patient in inefficient ways or like spending a whole bunch of extra money on the patient. If they are, and the managed care organization kind of deems that the doctor or hospital is kind of wasting their money, then they can just take the hospital or the doctor off of their in-network list. And then another tactic that managed care uses is they use salaries and fixed payments. So particularly the fixed payments component is important. We've talked about DRGs, diagnosis-related groups, and so a lot of managed care plans reimburse physicians based on diagnosis-related groups. In other words, the managed care plan will pay the hospital that's in their network a fixed amount based on the patient's diagnosis, which is independent of whatever care the physician provides the patient. So this gives the physician no incentive to kind of over-provide services to the patient because they're going to get a fixed amount of money. So the more you do to the patient, the more you're kind of just tallying up your internal costs without kind of an equivalent extra payment to support the extra costs you're generating. So if anything, fixed payments kind of have lead to an incentive for doctors to kind of under-provide care for patients. So there's definitely not any kind of incentive for a doctor to do extra stuff just for the sake of it. And then the last tactic that managed care uses to reduce moral hazard and physician-induced demand is they deny coverage for certain things. So there are a list of things that your insurance, if you have a managed care plan, will cover, and there's things that aren't on the list. And so the idea is that managed care plans, they kind of decide what are the super expensive treatments that we're not willing to pay for, and then they just don't pay for them. So if you get one of those treatments, they might just deny covering your expenses for that. Okay, so managed care, it has grown a lot in the United States. And by 2008, 98% of the people with private insurance in the United States were enrolled in a managed care plan. Again, there's two kind of flavors of managed care. There's HMO and PPOs. HMOs are completely vertically integrated, so the managed care organization will hire the physicians directly. PPOs are a little bit less restricted than HMOs. They don't completely integrate the insurer and the provider. Instead, the insurer restricts patients to a list of preferred providers. And basically the way this works is that a PPO will go around to different doctors and hospitals and they'll say, we will put you on our in-network list if you cut us a discount for every bill that you send us. And then they kind of find the physicians and hospitals that give them the best deal. If they give them a good deal, then they'll put that hospital or doctor on their list. And then for all the people who have insurance from that PPO, they'll give them the list and say, you can go to one of these doctors, PS, that has like given us a deal on all the bills they send us. And then if you go to one of those in-network providers, we'll cover you. If you don't, then we're not going to cover you. Okay, so that's kind of a real quick spiel on managed care. The second part of the American healthcare system is Medicare. So Medicare is universal coverage for the elderly and for the severely disabled. Okay, Medicare is structured with 4 parts. So you'll frequently hear people refer to Part A, Part B, Part C, Part D. And I'm just going to quickly explain these so you can understand what they're referencing. Okay, Part A pays for enrollees' hospital care. So all Americans in the United States who are above the age of 65 are eligible to enroll in Part A. Typically, Part A entails no premium. There's a couple of exceptions, but it's not really important that you kind of focus on those. By and large, if you're over 65, you get Part A Medicare for free, and Part A, again, will cover any kind of care that you receive in the hospital. Okay, Part B pays for outpatient care and physician services. So if you're an older person and you need to go to the doctor, that's not going to be covered by Part A, because Part A only covers hospital care. And so Part B would be the portion of Medicare that pays for the outpatient care and the physician services that you receive. Okay, like Part A, Part B is available to all Americans who are over the age of 65. Unlike Part A, Part B entails a small premium. So this is kind of a rough estimate, but for people who have coverage from Part B of Medicare, they're paying about $100 a month to get the Part B coverage so that their visits to the doctor's office are covered. Okay, Part C is kind of cool / kind of weird. So Part C provides an option for Medicare enrollees to receive their health insurance from a private plan rather than through the government. So Part C is a swap out for Parts A and B. So you won't simultaneously have Parts A, B, and C. You'll either have A and B, or alternatively, you'll have C. So the idea is that if someone who has Medicare wants insurance that is provided by a private insurer, then they will just go to the government. They would say, I would like Part C, and then the government will just pay a private insurer to provide the insurance coverage for the enrollee. Medicare Part C is often referred to as Medicare Advantage. It was implemented in 1997, and again, Medicare enrollees can opt to be a part of Part C, so it's not required. Again, if an enrollee opts for Part C, the government just contracts with the private insurer, and then they're going to pay the insurer a fixed amount of money per year, and then they basically just kind of wash their hands of the person and say, okay, now private insurer, you deal with their medical expenses. So the private insurer is then responsible for covering any services that traditional Medicare would cover, and it can attract customers if they can offer additional services, lower copays, or lower premiums. So the idea is that some people might be attracted to Part C because if the private insurer does a really good job of kind of managing the insurance coverage for people, then they might be able to provide a better or cheaper service to the Medicare enrollee. Okay, the last part of Medicare is Medicare Part D. Medicare Part D was established in 2006, so it's somewhat new, and it pays for enrollees' prescription drugs. So before 2006, Medicare did not cover prescriptions. So it would pay for hospital stays, it would pay for doctors' visits to the doctor, but if someone needed medicine, then Medicare didn't really cover that. And so because people who are elderly take a lot of medicine, in 2006 they decided they needed to introduce a part of Medicare that would cover prescription drugs. Okay, Part D is not free, so enrollees can pay some additional money for prescription drug coverage or Part D coverage. They don't have to buy Part D, but they can, and if they do, then Part D will cover their prescription drugs. And if a Medicare enrollee does enroll in Part D, then the coverage for the prescription drugs is administered by private health insurance companies. So again, like Part C, Part D is kind of administered such that the government contracts effectively private insurance companies to kind of manage that part of the insurance coverage. Okay, how does the government control costs in Medicare? The primary way there is cost control in Medicare is through diagnosis-related groups. So we've talked about these before, DRGs. But one thing that I've kind of mentioned as I talked about DRGs is DRGs, which as a reminder are payments that go to a hospital that are based on the patient's diagnosis and not based on the amount of care that's provided to a patient. DRGs are efficient at controlling costs, but there is a perverse incentive for hospitals to undertreat patients when DRGs are in place. So to kind of counter that perverse incentive for hospitals to try to save money by collecting the DRG payment and then doing next to nothing to the patient to keep their own internal costs low, the government established quality measure bonuses so that DRGs are still the name of the game, but if a hospital does a good job of caring for the patient, then the government will give the hospital bonuses on top of the DRG payment. And the idea is that this disincentivizes hospitals to just kind of collect the DRG payments, sink their own internal costs of caring for the patient down to zero. And because if they do that, then the patient will probably have a bad outcome. And if the patient has a bad outcome, or if their quality measure looks really bad, then they're not going to get the bonus from the government. So these quality measure bonuses are kind of layered onto the DRGs so that, one, the DRG kind of incentivizes the hospitals to keep their costs low, but then the bonuses incentivize hospitals to keep the quality up enough that they'll still get the bonuses. So examples of quality measure bonuses is sometimes the government won't pay for readmissions within 30 days. So the idea is if a hospital does a really bad job of caring for the patient, then the patient may have to go back to the hospital. So the government says in some instances, if you're taking care of a Medicare patient and the patient has to come back to the hospital within 30 days of their first visit, well then that seems like you didn't do a good job the first time. We're not going to pay for that second readmission within 30 days. If it's after 30 days, maybe if it's 2 years later, then presumably it's for some unrelated event, and then we'll give you payments for that. But there's kind of these nested incentives for hospitals to provide a high quality of care. Okay, Part 4 of the American model is Medicaid. Medicaid is subsidized coverage for the poor. Unlike Medicare, Medicaid is jointly run by the federal government and individual state governments. Okay, this has led to a number of things that are interesting. So there is significant geographic variation in what constitutes being poor enough to qualify for Medicaid. So because states can kind of make the parameters for who they want to give Medicaid to, some states say we will give Medicaid to people who have incomes that are below 100% of the federal poverty level. Other states say we will give Medicaid to people who have incomes less than 50% of the federal poverty level. Other states are super generous and they say as long as your income is less than 200% of the federal poverty level, we'll give you Medicaid. And so depending on where you live in the United States, you may or you may not be eligible for Medicaid, even with the same amount of take-home pay. Okay, another kind of thing that this has led to is that there's geographic variation in what services Medicaid covers. So because the states administer the Medicaid program, they can make the list of what treatments will be covered by this insurance plan. So in some states, I'm just making this up, this isn't exactly true, but maybe in some states, immunotherapy is covered by Medicaid, in other states it's not covered by Medicaid. And then the same is true for any kind of treatment. Like, the states can just decide we'll cover this or we won't cover this, and so different states make different decisions. Okay, the last thing is that there's also geographic variation in how much Medicaid reimburses providers. So what I'm talking about here is, suppose a physician decides I'm going to accept Medicaid patients. Well, they'll provide the care to the patient, but then they're going to get their payment from the state, and the state can decide how much they're going to pay the doctor. So in some states, they decide we're going to pay these physicians who cover or provide care to Medicaid patients pretty generously. And then other states, they're trying to save money, and they say, you know what, we have a fixed budget, we're not going to pay doctors that generously. And so by and large, the reimbursement rates to providers who provide care to Medicaid patients are very low, and oftentimes they don't even cover the cost of care. So many times Medicaid enrollees have a difficult time finding providers who will take their Medicaid insurance, because the doctors know, and especially in some states, that if they care for a patient with Medicaid, the state's not going to pay them that much to do it. And so withstanding doctors in the ER, they are free to kind of deny care to patients with particular insurances. And oftentimes they deny care to patients with Medicaid simply because some states get kind of stingy in how much they're going to pay the doctors for services rendered to Medicaid patients. Okay, the last thing I'm going to kind of close with for this class is a very small kind of selective overview of the Affordable Care Act. So the Affordable Care Act, otherwise known as Obamacare, was passed in 2010. And there are a couple of big kind of provisions that are built into the Affordable Care Act. So one of them was an individual mandate, which said if you live in the United States, you have to have insurance. We don't care where you get it from, but you have to be insured. The intention of the individual mandate was to prevent adverse selection. Again, adverse selection is healthy people dropping out of the insurance market because it's not kind of financially wise for them to pay for stuff that they're not going to be using. And so if there's an individual mandate, then healthy people in theory can't kind of jump out of the pool. And so this was intended to prevent an adverse selection death spiral. The individual mandate was struck down by President Trump, and so that's no longer in play. Another big component of the Affordable Care Act, as it was originally passed, was that originally every state was required to increase their eligibility threshold for Medicaid to 133% of the federal poverty level. So again, recall that because Medicaid is administered by individual states, what has traditionally been true is that states can just kind of set the threshold for the income levels that qualify you for Medicaid at whatever level they want. The Affordable Care Act said we need some minimum bar. So every state has to provide Medicaid for people whose income is lower than 133% of the federal poverty level. Okay, interestingly, when the Affordable Care Act initially went to the Supreme Court initially upheld pretty much all of the Affordable Care Act, except for this one part of it that said states had to provide Medicaid to everyone whose incomes are 133% of the federal poverty level or less. Originally, the Supreme Court, or I shouldn't say originally, the Supreme Court did say that the individual mandate was constitutional. It was still repealed by Trump, but that part was in place for a number of years. But one of the first things that got struck down was this mandatory expansion of Medicaid. So the policymakers, they kind of went back to the drawing board and they said, well, if we can't mandate that states raise their income eligibility threshold for Medicaid, what we can do is we can just provide big incentives for them to do so. So what the federal government did after the Supreme Court struck down mandatory Medicaid expansion was the federal government said, okay, states, you're free to choose whether or not you want to expand Medicaid. If you do, then we're going to 100% or almost like 99% pick up the tab for the cost of expanding Medicaid. Because if you're not paying for it, then in theory you should be happy to expand because it's on us now to pay for it. So perhaps unsurprisingly, states opted into Medicaid expansion or out of Medicaid expansion largely based on political affiliation. So on the screen now I have a map of the United States. The states that are shaded in blue are the states that have chosen to expand Medicaid at the expense of the federal government. So these states have taken their eligibility for Medicaid and increased it at least to 133% of the federal poverty level. And then that expansion has been financed by the federal government. The states in orange have not adopted Medicaid expansion. So they have eligibility for Medicaid that has not increased to 133% of the federal poverty level. So in the orange states, in other words, you have to be like especially poor to qualify for Medicaid. So the orange states did not adopt the Medicaid expansion, so they still have Medicaid programs that cover only the extremely low income, and they're not expanding it at the expense of the federal government. Okay, so that brings us to the end of everything. One final little thing I'll mention in case you would like to get more information on the Affordable Care Act. The textbook was written like right before Obamacare was passed. And so after it was passed, the author of the textbook, who's interestingly both a physician and an economist, he wrote one extra chapter that's available online in PDF form that's exclusively about the Affordable Care Act and Obamacare. So if you'd like to read that, just Google the textbook online. There's like this addendum chapter that's available on the textbook website that just exclusively talks about Obamacare or the Affordable Care Act. So read up on that if you're interested. If you have any questions I can answer during the next 10 minutes, let me know. And then after that, I'll see you back for the exercise. Okay, so to round out chapter 18, I'm going to do a little bit of a forced review for the exercise. There is an article that's going to be posted to Blackboard. It was published in the New York Times. It's called Back to the Health Policy Drawing Board. The reason I'm going to have you read this article is because it provides a really nice overview of kind of the American healthcare system and then a lot of the concepts that we've just discussed in class. So what I want you to do is I want you to read this article, and then I just want you to make a bucket list of every topic or concept or item that you find in the article that is something we have talked about in this class. So this article, it has a lot of stuff that we've covered. So be as exhaustive as you can. List every single thing that looks familiar, and then this will actually, it's an interesting article, and then hopefully this will also be just a nice review in terms of things you've learned this semester. So again, you don't need to write any sentences, just do a list of things that are familiar from the class, and then that will be it. So just as a final reminder, make sure that you come to class, the first class after Thanksgiving, because I'm going to explain what the final project will look like, so you're not going to want to miss that. Otherwise, I hope everyone has a wonderful Thanksgiving. I'm thankful to have you all in class, and hope you're able to go home and enjoy some good time to rest up. And then I will see you after Thanksgiving.